A very good afternoon, and we start off with the much awaited oration, the B.N. Chakravarty oration, which is going to be delivered by none other than Paula Amato. Paula is currently the president of the American Society for Reproductive Medicine. She's a professor of obstetrics and gynecology at the Oregon Health and Science University. Paula has chosen a very interesting topic for all of us, and I think this is something which is going to be the need of the hour, the intersection of infertility and intimate partner violence. Paula, the stage is all yours.
Thank you very much, Dr. Amit, and good afternoon, everyone. Thank you to the organizers for inviting me. I'm very honored to give this oration today. It is my first time in India, first time at ISAR, and I'm very much enjoying the conference in your beautiful country. Very appreciative of your hospitality, so thank you. So as Dr. Amit said, I've chosen to speak about intimate partner violence and infertility, a topic that I think is very important, but that we don't talk enough about, I believe. Although I was very pleased to see Dr. Shanta Kumari mention it in her talk on maternal care this morning. So I'm glad there's increasing awareness about this topic. What I'd like to do in the next few minutes is just talk a little bit about the relationship between reproductive health and interpersonal violence, review the prevalence of IPV both in low and middle income countries as well as the US, talk about the reproductive endocrinologist's knowledge and attitude toward IPV, and then finally the role of the healthcare provider in identifying and addressing IPV. I thought I'd start with a case from my own practice that I saw a few years ago. This was a 25-year-old woman with secondary infertility due to male factor. They were both international students from Saudi Arabia and the United States. They underwent IVF, and we froze 6 embryos for this couple. And then a couple of weeks after the retrieval, when she was supposed to come back for her transfer, we sort of lost touch with her, and we could tell from the electronic medical record that actually she had presented to the emergency department and had been assaulted allegedly by her partner. So this posed a lot of questions for us. Do we pursue treatment with this couple if they did come back while there was active domestic violence going on? If they didn't come back, which they didn't, what are we going to do now with their 6 embryos that we have frozen? And, is this reportable? Domestic violence is not mandatory to report in the United States, but there was another child in the home, and that is reportable. So it raised a lot of ethical issues for us. Intimate partner violence, as you know, is this pattern of assaultive and coercive behavior that can take many forms. Most commonly, it can be physical violence, but it also includes psychological violence, economic coercion. There's a variety of different manifestations. It can have lifelong consequences, as we know, both on mental health and physical health. It's very prevalent, and this is a global problem. About 1 in 3 women in the world have experienced IPV at some point in their lifetime. And of course, the true prevalence is actually unknown because there's this fear to disclose and the stigma associated with IPV. A related concept is reproductive coercion, and this is a form of behavior primarily to maintain power and control related to reproductive health. Most commonly, it can occur as birth control sabotage, for example, pregnancy pressure, or pregnancy coercion, meaning sometimes forcing a woman to become pregnant when she might not want to, or continuing or terminating a pregnancy against her wishes. And we know that there's a strong link between reproductive coercion and unintended pregnancy, requests for abortion, sexually transmitted infection. So if you see people in your practice presenting with these things, it's always important to include the possibility of reproductive coercion in the differential diagnosis. The consequences, of course, include acute injuries, but also some non-acute presentations, such as chronic pain, for example, mental health issues such as depression and anxiety and substance abuse. And of course, if domestic violence occurs during pregnancy, that's associated with poor neonatal and maternal pregnancy outcomes. Homicide is actually one of the leading causes of maternal death in the United States, and most often perpetuated by an intimate partner. Not to mention the healthcare costs associated with IPV and other forms of violence. There are some groups that are particularly at risk, namely adolescents, immigrant women, women with disabilities, and older women as well. And as far as the perpetrators go, some risk factors include lower levels of education, and exposure to child maltreatment, witnessing family violence as a child, personality disorders, substance abuse, and in societies where there's more gender inequality. I don't have to tell this audience, obviously, that infertility is very prevalent. 1 in 6 people throughout the world, the latest estimates from WHO released last year. And I mentioned that IPV is also very prevalent, but there's less data on the incidence or prevalence of IPV specifically in the infertility population. We know that infertility can be associated, as I said, with economic, psychological, and physical stressors, and these in themselves are risk factors for IPV, but infertility may be an independent risk factor as well. And as we know, there are disparities in infertility access in many parts of the world, including the United States, and as we heard in India as well, which can then translate to disparities in the prevalence of IPV as well. And even though we know that male factor accounts for about 50% of cases of infertility, somehow women are primarily blamed for infertility and suffer the brunt of that burden, especially in societies where there's a premium for childbearing. And several studies show an association between infertility and domestic violence by intimate partners, as well as sometimes other members of the family or the community as well. So the best data we have in low and middle income countries comes from this meta-analysis and systematic review published a couple of years ago that looked at 30 relevant studies, and it showed that basically 1 in 3 women in these countries suffer IPV over the last 12-month period, and lifetime is almost 1 in 2. And that women with infertility had a higher prevalence of IPV compared to women without infertility. The most common was psychological violence, but also physical and sexual violence as well. But there was significant heterogeneity amongst the study included in this systematic review. I thought I'd show just some visual prevalence data. This is not in the infertility population specifically, but just worldwide, you can see, if you look at India, for example, it's a little bit higher than some places, but a lot lower than other places, namely the African continent. This is data from WHO, shows similar finding, lifetime prevalence in Southeast Asia of about 33%, 1 in 3, consistent with the other data that I showed you. If you look at specific countries, you can see that India has IPV lifetime prevalence of about 35%, which is actually lower than Bangladesh and Timor, but higher than some other countries in the region. And if you include IPV plus non-partner sexual violence, you can see that the lifetime prevalence, the bottom there, is about 34% in the region, which is just slightly higher than the global average of 31%. So very, very common. And if you look at the age distribution, as expected, the highest prevalence is during the reproductive years. If you look at more granular data, this is from the India Department of Health Services statistics. There seems to be some regional differences with slightly higher prevalences in south of India, and you probably know better than I do what some of the reasons might be for those regional differences. And if you look at the percentage of women who are exposed to IPV who actually report, it's very, very low. In India, it's only 11% of women who have experienced sexual physical violence actually tell anybody about it. What about in the US? And to be clear, IPV is a big problem in the US as well, but we have less data specific to the infertility population in the US. This study was published last year looking at a specific cohort of women, women who were postpartum. So they had just delivered a baby. This study took advantage of something called a PRAM survey. So this is a survey given to all women in the United States after they deliver. And in 12 states in the US, they actually asked about prior fertility treatment. The prevalence of infertility treatment was about 13% in this cohort, and the prevalence of IPV was 2%, and they only asked about physical IPV, not all forms of IPV, and it was not higher than the fertile population in this cohort, and we'll talk about some of the reasons that might be. But even in this study, there was an association, for example, with non-white race, lower levels of education, higher levels of poverty, etc. The reason that the prevalence might be lower in this study than other studies is, like I said, they only asked about physical abuse. It's limited geographic catchment area, only 12 states, and it was a population of women who actually successfully conceived and delivered a baby, which might not be representative of the entire infertility population. But this is basically the only data we have in the United States in the infertility population, so clearly there's a need for more research. This is a busy slide, I don't expect you to read it, but only to point out that COVID was horrible for victims of domestic violence. Women were stuck at home, often with their perpetrators, and they had less access, more stressors, less access to support services as well. So this was a huge public health problem. What about if we look at what physicians or providers know and what their attitude is towards IPV? This was a study published a couple of years ago that surveyed 200 fertility clinics in the US, the medical directors, and almost 60% actually recognized infertility as a risk factor, which is actually pretty good. And there was a negative association between prior training in IPV and beliefs in myths. In other words, if they had training, they were less likely to believe myths associated with IPV. But less than 20% of the respondents knew that their clinic had any policies related to IPV. And some of the barriers that the providers mentioned was lack of knowledge, lack of time, of course, discomfort with the topic, and just lack of familiarity of what to do if you screen for IPV and someone says yes. They were just unfamiliar with what to do in that situation. So we can see that infertility and IPV share many challenges, including stigma, cultural ramification, disproportionate impact on specific populations, and both can lead to psychological health issues and physical health issues. So what to do? So in the United States, both ACOG, the American College of Obstetricians and Gynecologists, and the United States Preventive Services Task Force, they recommend screening all women of reproductive age periodically for intimate partner violence. This differs a little bit from the WHO recommendation, which is to do more targeted screening, and this is based on grade B quality evidence in the US. So it's important to incorporate screening into the routine medical history. It's useful to provide a framing statement to show that this is done for all patients, not that you suspect IPV or etc. This is just, we need it to become routine, something we ask routinely. Of course, you want to screen for IPV in a very private and safe setting. When the partner is not there, ideally, you want to use professional language interpreters if necessary. You want to inform patients about confidentiality, that what they share will be confidential unless the law requires you to report. And it's important to have relationships with the community's services in your area, domestic violence agencies, etc. And it's also useful to have printed educational materials, perhaps in your waiting room or clinic, because it's been shown that even if patients don't disclose, if they see like a poster or a handout that talks about IPV, that has an effect on them. They may be more likely to disclose next time, or at least they know that help might be available if at some point they choose to disclose. And of course, we have to train all our staff to be able to identify and address IPV. You want to use a trauma-informed care approach. So you want to acknowledge the trauma, assess the immediate safety of the patient and her family, and develop a safety plan. And as I said, often the local domestic violence agency, at least in the US, is the best resource. I'm sure you have similar services here in India. You should have a private phone available to call a hotline if that's something that's available in your community, because of course perpetrators can sometimes monitor people's cell phone, etc. So you want to give them a private phone. And there should be protocol in the clinic and what to do if somebody screens positive. And in the United States, at least, it's important to know that there's mandatory reporting of child abuse. These are just some examples of kind of scripted questions that you can use. A framing statement. We've started talking to all our patients about safe and healthy relationship because it can have such a large impact on your health. Confidentiality, some sample questions. Has your partner ever threatened you or made you feel afraid? Has he ever hit, choked, physically hurt you? Has your partner ever forced you to do anything sexually that you didn't want to do? And also I should point out that we're talking mostly about women as victims of domestic violence, but also men occasionally, less often, but are also sometimes victims as well. And this is not something that occurs just in heterosexual relationships, even same-sex relationships, there's also a high prevalence of IPV. We should educate our patients about safety planning and support services. Sometimes the best approach is to provide what we call harm reduction strategies. So for example, very discreet or confidential methods of contraception, like an copper IUD that's less detectable by the partner, and some more questions for you to assess for reproductive coercion more specifically. The trauma-informed care approach recognizes that traumatic experiences are terrify, overwhelm, and violate an individual, and seeks to not repeat these experiences and to provide a sense of safety and power and worth to the individual. Again, some sample scripts, and I'm happy to share my slides afterwards as well. Avoid doing non-evidence-based exams. It's rarely necessary to do routine bimanual exams, for example. You can use less intrusive ways to obtain data and samples, such as self-swabs, for example, for GC and chlamydia, and utilize the principles of shared decision-making. And just some subtle, changes in languages sometimes can be very impactful to patients. So instead of saying, for example, you're going to insert the speculum. This applies, mainly to victims of prior sexual violence. You're going to place the speculum. Instead of telling patients to hold still and relax, you can tell them, if you need to move, wiggle your toes, squeeze your hands, try to keep your pelvis resting. It's very subtle, but to the patient who is a victim of sexual violence and has PTSD, it can be very important. And don't forget to care about your team, as well as we heard in an earlier talk about physician wellness. It can be, very difficult to deal with patients who are exposed to trauma, and even providers can vicariously suffer from that trauma. So make sure you care for your staff as well. WHO has made put a big emphasis on violence against women, and all this information is available on their website. They have what they call a global plan of action, and they have a program which they call Respect Women, which stands for Relationships Strengthened, Empowerment of Women, Services Ensured, Poverty Reduced, Environments Made Safe, Child and Adolescent Abuse Prevented, Transformed Attitudes, Beliefs, and Norms. A lot of work needs to be done, and again, you can look on the website, but this involves policies and laws, doing more research, prevention, providing services and support, and the hardest thing, perhaps, is changing societal beliefs and norms. So to conclude, IPV is highly prevalent, it's likely underestimated, certainly understudied, so we definitely need more research. There's a bidirectional association between infertility and IPV. Infertility can be a risk factor for IPV, as we've seen, but IPV can also sometimes cause infertility because of the chronic stress. Sometimes sexually transmitted infections that result as well can contribute to infertility. And definitely more education is required of healthcare providers. So the recommendations, again, are to routinely screen women for intimate partner violence and sexual coercion. And the preconception period when someone presents with infertility is a very unique and novel opportunity to do so. Try and integrate your screening tools into your routine intake questionnaires. It makes it a lot easier. Educate your patients, counsel them, provide protection against unintended pregnancy and harm reduction strategies and safety planning. And we all need to do the hard work of addressing the structural issues that are part of the root cause, such as gender inequality. I have some resources here. Many of these are US-centric, but the WHO, like I said, has a number of good resources on their website. And I would like to highlight also Futures Without Violence, that has a number of patient-directed educational materials that can be customized to your area as well. Again, thank you very much for the opportunity to be able to give this oration. Thank you.
Thank you, Dr. Paula, for this detailed yet concise and conclusive, discussions and guidelines on something which is so much unspoken. We don't really discuss it, but I think after the discussion today, many of us are going to make it a part of our routine practice. Thank you so much, and welcome to Orissa. Thank you.
Hello, thank you very much. This is an important subject, and all of us who practices infertility, they get this type of couple very much, where the violence of the male partner on this lady. And thank you very much for your lovely oration. Thank you.
I would like to invite Paula in the center so that we can present you the plaque. Can I have the plaque, please? So the plaque reads as the 20th Annual National Conference of ISAR, Conference Oration delivered by Dr. Paula Amato on the topic of intersection of intimate partner violence and infertility on the 3rd of February at Bhubaneswar, signed by Dr. Nandita Palshetkar, President of ISAR, and Dr. Sujata Kar, Secretary. The theme of the conference being navigating the new normal in ART. Paula, thank you very much for coming down and being with us. Yeah. Please. Is it? No.
immediately